Hello, everyone. This is Dr. Siddharth Tambar. Thank you for joining us in our webinar today. Today, we're talking about how can regenerative medicine help in our inflammatory arthritis patients. This includes our autoimmune inflammatory patients, conditions like rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, and other related conditions. As we're going along today, please type in your questions and I will answer intermittently as we go along. And after we're done today, if you have any other questions, please feel free to either message us either through the website, social media sites, email, call us, and you'll also get a replay of this whole presentation as well. Okay, great. Okay, so what you'll get from today's webinar, we're talking about non-surgical treatments for arthritis and tendonitis that do not require surgery, what is legitimate, not legitimate in the field of regenerative medicine, how to choose the right regenerative medicine treatment for your condition, and how do regenerative medicine treatments fit in inflammatory arthritis. So briefly, a little bit about me. My name is Siddharth Tambar, physician here at Chicago Arthritis, specialist in rheumatology, image-guided injections, as well as regenerative medicine. In practice since 2008, involved in regenerative medicine since 2008 as well, and part of the Regenerative Network, which is the largest network of physicians involved in regenerative medicine. I've been involved in that network since 2012. So how did I get involved in this? Essentially, when I had first started practice, I was learning about musculoskeletal ultrasound. I didn't have any shoulder pain at the time, but I did play a lot of tennis when I was younger, and I noticed that I had some mild chronic rotator cuff changes. That got me thinking about how we're treating tendon and ligament injuries more. That got me involved in platelet-rich plasma, then prolotherapy treatments, and then eventually over time, also in bone marrow concentrated stem cell treatments as well. Traditional care for a lot of these things is primarily pain medications, traditional injections that are just blocking pain, and then just treatments that are masking pain, then eventually waiting for surgery. And in some cases, surgery is appropriate, but in some cases, it's overkill, and there's obviously more risk associated with surgery. So in looking for better options, we need options that are lower risk and avoid serious side effects. They should address the actual source of the problem, which is either instability or inflammation, and they should improve the actual cause of the problem because that will give you a better chance at long-term improvement. Again, if you have any questions afterwards, please contact us via chicagoarthritis.com. So as a rheumatologist who's also involved in regenerative medicine, I think I have a fairly unique perspective on this in the sense that I see what inflammation is about. I also see what instability is about. And there are dozens of different types of arthritis conditions. And systemic arthritis or inflammatory arthritis is one type. And degenerative arthritis or tendonitis is another type. And I think as a rheumatologist, I can say that if you're treating the cause of the problem, either it's instability in degenerative arthritis and tendonitis, or it's inflammation in inflammatory arthritis, that's how you get the best outcomes for patients. So regenerative medicine is the process where we take your own cells and we use that to treat musculoskeletal problems. So in the normal healing process, take something as small as a cut on your finger. You have platelets that first come into the area. They stop the bleeding. They then release growth factors, which then stimulate your local mesenchymal stem cells, which then brings in other cells and growth factors. That's experienced as inflammation. And that slowly, progressively repairs things at a cellular level. So this works very well for tissue that has good blood supply. For tissues with not as good blood supply, that can include tendons, cartilage, ligaments, discs, labrum, menisci. These are all musculoskeletal tissues. Once they've been significantly injured, they tend not to heal very well on their own. So regenerative medicine is the process where we take those same cells and we coordinate the normal healing process by injecting those cells into the tissue that has been damaged. Okay. So how does regenerative medicine work? It will optimize the cellular health of damaged tissue. It will improve strength and stability. Excuse me. It will improve the strength and stability of supportive ligaments, tendons, and other soft tissue structures. It'll reduce chronic inflammation, and it will improve your overall neuromuscular health if we treat the surrounding nerves and muscles as well. So inflammatory arthritis. What is inflammatory arthritis? So the source of the problem in inflammatory arthritis is that it starts with something that's triggering and causing inflammation. So in autoimmune conditions, it means that your immune system is miscommunicating, and instead of just protecting you from bacteria and viruses, it's now attacking your own body. And in conditions like RA, psoriatic arthritis, ankylosing spondylitis, lupus, and other similar conditions, that is causing inflammation in the joints. Other types of inflammatory arthritis include conditions like gout and pseudo-gout, where there's small little crystals where your body's not metabolizing it correctly that can get deposited into the joints and cause inflammation. And there's other types of inflammatory arthritis as well. So the typical approach to inflammatory arthritis, if you have an autoimmune condition, is to utilize medications that control the immune system. And that is correct and appropriate in the vast majority of those patients. In crystal arthritis, you basically have to control the development of the crystals, and there's medications to do that. In general, for these conditions, when you look at the data and the evidence, for most patients, this approach works well, medications. And the potential risks of treatment are generally significantly outweighed by the benefits. And we know that because for some of these meds, where people have been on these for decades, you find conditions that previously would have been progressively worse. Now people are put into some kind of remission or low disease activity status. So could Regen Med, what is its place in inflammatory arthritis? There's a few different ways. There's different types of regenerative medicine options that already are helpful. And here's some of them, and this will only grow over time. Alpha-2 macroglobulin is a strong anti-inflammatory molecule that comes from your own blood. We are able to concentrate that from your blood or bone marrow, and that is helpful for pain relief and in reducing inflammation. Interleukin-1 receptor antagonist protein. This treatment has been around for over 20 years. It's a strong anti-inflammatory that it can be concentrated from your own blood or bone marrow and can be injected into tissue that's been damaged or rather inflamed. Platelet lysate is a type of platelet-rich plasma where we just take the growth factors from the platelets. It gets the same benefits of PRP, but without the inflammation. Bone marrow concentrate is where we take your own bone marrow, concentrate into a high concentration of your own mesenchymal and hematopoietic stem cells. It also has other growth factors and platelets, can be helpful for pain and inflammation long-term as well. So these are potential treatment options that may make sense in inflammatory arthritis. So let's talk about where this fits in now. So to begin with, understand that there's really mainly just small case studies or series of cases that have been kind of put together when you look at Regen Med treatments in inflammatory arthritis. First-line treatments still remain the traditional medications. And again, the reason why is you literally have over 20, 30 years worth of data for some of these medications. Regen Med treatments as a primary treatment for inflammatory arthritis still remains an experimental concept. So what I generally recommend is if you have severe inflammation throughout your body, you should first try to control the inflammation. So as an example, we'll get patients who, for a second opinion, they may be on medications for their rheumatoid arthritis or psoriatic arthritis, and they want to know, could using their own stem cells or platelets be useful in their case? In many of these cases, these folks still have very severely active autoimmune issues, in which case I'll always guide them by saying you should really get that big picture issue under control first. To me, this applies regardless of what the source is. Let's say you have forget about chronic inflammation. Let's say you have very uncontrolled hypothyroidism that's leading to pain and swelling in the joints. Well, the goal should be first treat your underlying systemic condition, and then let's see what else we can do if needed. because in a lot of cases, if you treat the bigger picture issue, your joints generally get better. However, inflammatory arthritis patients can still have pain, even if their overall systemic inflammation is under control. So after controlling the overall inflammation, if you still have pain that's coming from osteoarthritis, tendonitis, chronic instability, or nerve entrapment, these are great uses of where Regen Med can be helpful. You treat the instability, you treat the chronic degeneration, and it makes a big difference in terms of pain, instability, and function. Keep in mind also that folks who've had chronic inflammation in the joints are more prone to things like osteoarthritis and tendonitis. And so these end up being issues that they're living with anyway, and we can still help them out with that. And in fact, it's a better option than the traditional options, which includes steroid injections, pain meds, and nerve blocks, which are not really fixing the problem for people and are frequently utilized just because that's what's available in the clinic. But here's some other practical uses of possibly Regen Med in inflammatory arthritis. Let's say you have very mild inflammatory arthritis, maybe only 1 or 2 joints are involved. Well, would it make sense to treat that with, let's say, your own bone marrow cells? Possibly. Let's say you have well-controlled systemic inflammation, but you have 1 or 2 joints that are still slightly active. Well, that might be a case where this could still be useful. Here's an example of that. So a patient of mine patient of a colleague's who's on treatment for their RA. They've had RA for 30 years. They've already had damage in their joints, but generally their inflammation's under good control now. They've had persistent pain and swelling in both knees. They have a lot of chronic damage, wear and tear arthritis in the knees. When you drain the fluid from the knee, there is a little bit of inflammation. So the overall sense is that their RA is controlled and that their knee pains are primarily from their wear and tear arthritis, although there may be a little bit limited kind of RA activity still in the knees as well. In this individual's case, because his overall inflammation was generally under control, we ended up using his own bone marrow cells for both of his knees, and he's done absolutely great over the last several years. That's a good use of where you're combining traditional with Regen Med, and someone's done very well. Another example would be, let's say, someone who has a contraindication to utilizing the traditional medications for inflammatory arthritis. Let's say they've had too many side effects. Let's say they maybe have had some other medical problems. Well, this may be a case where it may be worthwhile to try more of an experimental approach. Now, realistically, if you have 20 plus joints that are inflamed and active, it's hard to really properly treat that with Regen Med. It's a lot of joints. Regen Med works by injecting directly into the joint. It's not an IV treatment. Number one, there's really no evidence that IV treatments with these kind of modalities make sense or is helpful. Also, it's considered illegal in the United States to do that. So it's a case-by-case process, but in some cases, this can still be very helpful. So people with inflammatory arthritis have higher rates of osteoarthritis and tendonitis, wear and tear issues as well. So in a lot of these patients, Regen Med treatments with either your own bone marrow stem cells, platelet-rich plasma for osteoarthritis and tendonitis can work very well in folks who also have inflammatory arthritis. And again, it works because it can help to reduce inflammation in the joint and because it also can improve instability. Actually, just before we move on, let me just pause for a moment, please. And again, as we're discussing, please add in any questions that you may have. Okay, good. So let's talk a little bit about how you, as a patient, as an individual, how you actually vet whether or not you're seeing a provider that knows what they're doing with these kind of treatments. Number one is they need to be a musculoskeletal expert. That means is if your doctor is someone who is treating like someone else's high blood pressure, somebody else's erectile dysfunction, and then they're walking in to treat your knee, it's probably not a musculoskeletal expert. They're doing too many other things. Number two, they want to be a non-surgical musculoskeletal expert. So we have orthopedic surgery colleagues who are very good at their craft, which is surgery. they don't necessarily have as much experience with these kinds of treatments or the modalities you need to do these treatments correctly. For example, they may not have as much experience with image guidance during injections and procedures. That includes ultrasound and X-ray. It's largely because they just haven't been trained in that. And to do these treatments correctly, you need to be so pinpoint precise. You can't just be around the joint. You have to be directly in that one spot, and that's it. And so image guidance is very important. Being a non-surgical MSK expert is very important. Then they should understand how inflammation is utilized here. So as I mentioned, you've got chronic inflammation in autoimmune conditions. That has to be treated differently. But then there's how do you harness inflammation when it's normally meant to help actually recover after an injury? And that's how regen med treatments work, by creating a little bit of early inflammation. And if you do it correctly, it can make a big difference in people. But I certainly have colleagues where they don't have an understanding of differentiating between chronic and acute inflammation and how to harness that power. And they end up relying on things like steroid injections that are really progressively damaging the joint long term. Then they should understand the different types of biologic treatments that are used. Too many colleagues where they may be involved in these kind of treatments, but they do this as a one-size-fits-all approach. And they don't really understand when is somebody an appropriate candidate for bone marrow versus platelet lysate. They also don't give you a personalized treatment plan. They're giving you a one-size-fits-all plan. So the way you would utilize a higher dose of platelets in one person versus a lower dose in another person, there's reasons for that. And some of my colleagues don't have that understanding. So you need to find a physician that has that kind of nuance and understanding. They need to even understand the concept of prolotherapy. Prolotherapy is an old school concept. It's about treating instability. I'll talk about that in a moment later. But most folks who do these procedures don't really get that. And that's an essential part of these kind of treatments if you want to improve instability. And then they should be transparent regarding your results and candidacy for treatment, meaning it shouldn't just be everyone gets treated. It should be, here's what your expected outcomes are. Here, are you a good, fair, or poor candidate? And what makes you that as well? They should follow your results long-term. They should not just be they do a procedure and you never see them again. And they should guide you through the process. These treatments are newer. Your physician needs to be an expert. And so they should be able to guide you through this properly. Some other basic questions. Is this legal? Simple answer is yes. There are some very strict guidelines from the FDA. If you follow those rules, then yes, 100% this is legal in the United States. If I'm older, shouldn't I use someone else's cells? That's something you'll hear some clinics say. And they'll say that because they're trying to get you to utilize an amniotic fluid or placental product, which is incorrect. You should still use your own cells. To begin with, for the vast majority of orthopedic conditions, there's very good evidence that using your own living cells is still effective. There's also risk if you use somebody else's cells, like rejection and things like that. And then is there an age limit? For the vast majority of conditions, no. The one exception would be hips, where if you're over the age of 65, your outcomes can be worse. But everything else, age, in the studies that have been done, do not show that people do worse. Ideally, we'd all stay 25 years old for the rest of our lives, but that's not the case. And most of our patients tend to be 60 plus. And so absolutely, even if you're older, you can still do well with treatment. Again, what sort of doctor does these treatments? We talked about this, but it has to be really a proper regen med expert. Can these treatments help if you already had surgery? Depends on the surgery. So if you had, let's say, an arthroscopy surgery, laminectomy, or some other kind of surgery like that, yes. If the joint's been replaced, well, we're not injecting into the joint. You may have some soft tissue issues. You may have some nerve issues. We can still treat that. Just we wouldn't inject into the joint if there's hardware there. My general rules and recommendations for patients who are looking for orthopedic surgery are, number one, try to keep your own anatomy if possible. Avoid surgeries that are just cutting out tissue. Always consider a regen med treatment option if you've been recommended surgery to see if that is a reasonable option in your case as well. Let me just quickly, I see a question here. Somebody asking, would regen med work if they're on a biologic and if they're on small doses of prednisone? It's a good question. So prednisone is the issue there. If your condition is generally controlled on your biologic, that's good. If you're still on prednisone, it has the potential to limit your effectiveness with treatment. Now, with that said, I have treated patients who are on like up to 10 milligrams per day of prednisone who've been on that for decades. As a rheumatologist, I don't feel good to see that a patient is on long-term prednisone like that. But for what it's worth, when we have treated patients who are in that situation, they actually did okay with treatment. You still give them that caveat that there's a possibility that your prednisone may limit the effectiveness of treatment, but in my experience, they've still done okay. But if you can reduce it below 10 milligrams, that is better. Somebody else asking, is this fixing the issue or is it a temporary fix? It's a good question. So essentially, we are treating with the root cause of the problem, which is instability and inflammation. The reality is that if you catch somebody who has a condition for, let's say, a few months, well, you can reverse that. If you're talking about someone that's had something for decades, you can't fully reverse decades, but you can optimize the joint, maximize stability so that you get a better joint long-term. Now, you have to think about, why do you still have that problem developing in the first place? Have you had other injuries? Are you prone to injuries? Do you have chronic instability? Do you have some other chronic inflammation issues? Has there been something else that's driving this to begin with? And so we can optimize the joint as much as possible, but if there's something else still driving the problem, it may recur again. And also keep in mind, we cannot reverse the clock by decades. It's just not possible. If we could catch your issue earlier on, then there is a chance of really reversing things. But if we're catching something that's more chronic in nature, then we're trying to optimize things. Okay, so some very key concepts when it comes to regenerative medicine that we'll be talking about here. Excuse me, give me a moment. Okay, great. So, stability. There's this concept in architecture called biotensegrity. What it means is that if you have individual units in a structure that'd be weak on their own, if you put them in close approximation and compress them, the overall structure is stronger than the individual units separately. This concept in biology is called biotensegrity. So in architecture, tensegrity, in biology, biotensegrity. Prolotherapy is the idea of injecting solutions or your own cells into the soft tissue supportive structures around a joint to strengthen it and stabilize it. The key is to treat all the different layers and depth of the tissue that are involved and understand that there's a progressive strengthening over time and that this tends to give longer lasting results over time. So as a concept, prolotherapy means that you're strengthening the ligaments and soft tissue structures to optimize a joint functional unit. As a treatment, more specifically, that can be basic treatments like dextrose prolotherapy, so the original regenerative medicine treatment, where you're using a solution dextrose, causing a mild degree of inflammation as you inject it into tissue that's been damaged, to then strengthen it and improve it long-term. More advanced version of this is using your own cells, either your own platelet-rich plasma, platelets, or your own bone marrow cells. So to give a sense for how these treatments work, dextrose prolotherapy is milder. We recommend monthly treatments for 3 to 6 treatments. PRP, we recommend treatment on day 1, and then considering repeat treatment at the 6 to 12 month mark, depending on how you're doing. For bone marrow-derived stem cells, treatment on day 1. If needed to repeat treatment, it'd be in 2 to 5 years, basically. It's a case study of a lower back, 71-year-old man, history of, at baseline, he's got ankylosing spondylitis that is under control. He also has some chronic degenerative issues. He's had prior even lumbar surgery, laminectomy, without much benefit. We ended up treating the ligaments, the facet joints, muscles, and epidural space. Originally with platelets, he had some relief. We then escalated to bone marrow. He's doing much better. What I like about this case is to show how even if you have an autoimmune issue that's under control, that chronic wear and tear may still be a problem, and we can still treat that. how it's important to sometimes escalate treatment from just a milder treatment to something stronger, and how we can still treat things even if you've had prior surgery. Next concept, orthobiologics. These are the cells and tissues that we inject into damaged orthopedic tissue. Again, this utilizes the body's normal healing process. And again, please use your own cells, not somebody else's. In part because that's where all the data is, in part because that's where all the safety is. So first line orthobiologic treatment to be aware of are platelets. Again, after an injury, platelets are recruited to start that healing process. This utilizes focused inflammation to help repair damaged tissue. And your own platelets, they basically release growth factors that stimulate your local mesenchymal stem cells. There's platelet-rich plasma, where we take your blood, concentrate to a high concentration of platelets, and then inject that into the tissue that's been damaged. And there's platelet lysate. We take those same platelets, crack them open, and just take the growth factors. So we use platelet lysate to treat nerves and ligaments that tend to be less inflammatory. We use platelet-rich plasma for joints and tendons. It's a little bit more inflammatory, but it does a better job for joints and tendons. Picture on the right are two different types of platelets. You want the type of platelets that have the amber color, not the one that has the red color. The red color are more red blood cells. You don't want that. It's more inflammatory. Case study, individual, middle-aged man, knee tendonitis, it's a cyclist, regular person, but cycles a lot. Referred to me by a sports medicine physician. Picture on the right is of an ultrasound. Not sure if you can see my cursor, but that's the tendon, that's the bone, the kneecap, and these are some enthesophytes, a little bit of bone spurring. That's his tendonitis. This picture, that's a needle injecting into the tendon. We treated him 2 times over 6 months. He was able to get back to full capacity, and he's doing great. But a few years later, we then presented with a hamstring issue on his other leg now. Again, treated that and back to full activity level. What I like about this case is how well platelets can work for tendon and soft tissue issues, as well as how repeating treatment can be useful. Next, orthobiologic to be aware of are your own stem cells, main tissue that drives recovery after an injury. Please use your own cells, not somebody else's. In the United States, bone marrow-derived stem cells are the only legal product for live stem cell treatments. Fat cells, fat stem cells are considered not legal in the US because of an enzyme that you need to break down the fat. You can still use fat and adipose for structural support. So for let's say someone has a tendon injury, sometimes we'll combine adipose, fat, if you will, for the connective tissue, along with either bone marrow stem cells or platelets to help try to repair that soft tissue injury. You probably hear about amniotic and umbilical cord cells in this country. Understand that the way these products are processed by the manufacturer, there are no living cells. So it's not a stem cell treatment, it's more of a growth factor treatment. You're better off just using your own blood platelets. You may hear about IV stem cells in other parts of the world. Very limited evidence on whether this even helps with orthopedic conditions, and equally as important, considered illegal in the United States. The way that we would kind of come to a decision as to what treatment or if you should get treatment is we look at a few things. What's the severity of your issue? All right, and what area is affected? If you have advanced knee arthritis, still very treatable, you're better off doing bone marrow rather than platelets though. If you have advanced hip arthritis, harder, we generally refer you for surgery. Next is, what are the medical contraindications do you have? Let's say you have an active cancer, you're getting chemotherapy. That's not the right time for something like bone marrow or platelet-rich plasma, although we could still probably use we could probably still use Prolotherapy as an option in that case. So what other medical issues do you have? And is this an initial treatment versus a booster treatment? Let's say you get an initial treatment with your own bone marrow stem cells, and we need to top things off at the 1-year mark. Well, we may just use platelets at that point. You don't need to do bone marrow again. And then, of course, cost, right? I mean, like, most of these treatments are not covered by insurance. Some of them are, if you're part of the Regenerative corporate plan, but many people are paying out of pocket, in which case cost can be a consideration as well. What about outcomes? Yes, we can improve pain and function even in advanced cases. Can we improve how your images look? And I'll show you some what we can do. If you have advanced arthritis, it cannot get your knee to look like on an x-ray what it was 20 years ago, 30 years ago. If you have a tendon tear or ligament tear, if that tear is less than 2 centimeters, we can actually get that to look normal and function normal. If you have swelling in arthritic joints, that can resolve. If you have swelling in the bone, or if you have avascular necrosis, if we're catching at an early stage, we can still reverse that as well. So can we treat bone-on-bone arthritis? Again, depends on the joint. With hips, cannot do that. Would recommend surgery for advanced hip arthritis. Other areas, yes, can still be helpful. And the reason why is arthritis is a biologic condition. It is treatable with these orthobiologic treatments. In particular, if your range of motion and function are still relatively intact, good outcomes are still possible if that's the case. Some caveats again, we can improve pain and function. Improving your actual imaging is less likely. All right, that's unlikely. We cannot reverse the clock by decades. What about tendon and ligament tears? Partial thickness tears, definitely full thickness tears. As long as the tendon is not fully apart, but it's still in close approximation, we can still treat that. So this is a case of a 28-year-old man whose ACL we treated. And this is a picture of his procedure. The long needle structure is the needle. What's lighting up is his ACL. We're injecting a little bit of contrast in there. We injected his own bone marrow stem cells. In 2 months, he's doing great. At the 3-month mark, we rechecked. Not only is he doing well from a pain standpoint and function and escalating activity, we ended up doing an MRI again, and this is what we see. Picture on the left is his MRI pre-treatment. You see a tear. The radiologist read this as likely a full thickness tear. 3 months later after treatment, this is now a fully normal looking ACL, and the radiologist has read it as such as well. So these are doable things if you're catching things at the right stage. Let's say this person had a tear that was 20 years old. Unlikely you're going to get this kind of response. Key here is that we caught him at an early enough stage. It's a case of a rotator cuff tear, individual contractor, general contractor, rotator cuff tear on the right side. Pictures on the left are ultrasound images. This hole in the middle of the tendon, that is a full thickness tear. Pictures on the right, a few months after treatment. This is a tendon, essentially cells and tissue that are now in there, that are now starting to heal. He's done great with treatment. Interventional orthopedics is the last concept that you should understand. This is using image guidance to treat orthopedic injuries. Why do we need image guidance? So this is a picture on the left, rotator cuff. We're injecting that long, again, that literally labeled needle. Where you see the tip of the needle is a small little black hole. This is zoomed in, all right, on ultrasound. This is a 1 by 1 millimeter hole. To inject into that tear so precisely, you cannot do this blindly. You really properly need image guidance to do this. This is a picture of injecting into a shoulder joint under x-ray guidance and into the labrum. What's cool about this one is that little triangular structure is the labrum. How do you know you're injecting that properly? You need to do this under image guidance. Doing it blindly is not good. I showed these pictures before. The one on the left, patellar tendon treatment with platelets. The one on the right, ACL treatment with his own bone marrow stem cells. Again, in both cases, needing high-level image guidance to do this properly. It's an ankle AVN case, 41-year-old man. He's a cook, on his feet for 13, 14 hours per day. He had a little bit of swelling in the joint. He's got arthritis that's developing in the joint. He's also got a lot of swelling in the bone, described as avascular necrosis, damage in the bone. We injected into the joint, the ligaments, and into the bone. 3 months later, doing well. And here's his imaging where that prior damage in the bone, swelling in the bone, has resolved now. So he's doing really well long-term at this stage. Regenerative medicine treatments offer safe and effective solutions for your pain. Let me just take a moment, just look, see if there's any questions. Here's a question. Somebody asking, had rheumatoid arthritis in 2020. They stopped all medications for the last 3 years. Yeah, this one requires you to see a rheumatologist, please. The level of nuance and details here is something that really needs to be properly evaluated. Somebody else asking, Region Med providers, they're living somewhere in India. My recommendation is check on the Regenix.com website, see if there's anyone there. There may still be someone there who's part of the Regenix network. There used to be in the past. Okay, back to our presentation. So is this too good to be true? Look, there's evidence for these treatments. It goes back to the mid-90s from Dr. Philip Hernigue, orthopedic surgeon in France. Regenix network has data since 2005. These treatments, this is a rapidly developing field, but these treatments are not new any longer. My personal experience goes back to 2008. Originally, I had colleagues 10 years ago who thought these treatments didn't work at all. 5 years ago, they said they weren't sure. They kind of shrugged their shoulders. And now they claim to offer these treatments and claim to be experts, but they're still not sure if they work. So, there are right and wrong ways to do these treatments. Work with a professional who's an expert who knows what they're doing. Your expectation should always be grounded in reality and evidence-based medicine. Your physician should be an expert in the topic. If your physician is picking this up because they're looking for something new to add to their practice, that's not the right person to see. You don't want to be the first 100 patients that a doctor sees in something new. You want to be there 10,000, 100,000 patients. Like you really want someone who knows what they're doing. So how long do results last? Again, Philip Hernigue, Regenix has data that they have data that goes very long term. What I tell people is think conservatively. If you have a chronic condition, meaning you've been living with knee arthritis pain for 30 years, you need to expect that a repeat treatment or a booster treatment will be needed at some point. That might be in 3 to 5 years, it might be a year, it just depends on your particular case. Best ways to maintain your results after treatment: improve your biomechanics, work with a good physio, use the appropriate joint supplements that can help with inflammation and pain. Repeat treatment can be helpful at some point as well. Regenix actually has a study where they looked at using bone marrow, kind of in repeating bone marrow treatment. What they found was that people would get slowly improve, get to a certain level, and they would kind of plateau there. If they repeated treatment, they were now lifting up to another higher level after that. As much as possible, maintain your ideal body weight. Reducing stress will help to reduce pain in the back and the legs. Improving your metabolic health can improve inflammation, which can improve pain and swelling in the joints. Believe in this so much that we have our own sort of physician-assisted weight loss program to help our patients achieve that as well. Strongly recommend looking into weight loss if you need to improve your weight and metabolic health. We talked earlier about all the things that you need when it comes to selecting your Regen Med expert. I go with this. It's a long list, but you want someone who really meets all these criteria. A little bit about us here at Chicago Arthritis and Regenerative Medicine. We focus on non-surgical treatments for your arthritis, tendinitis, injuries, and back pain. Start with evaluating for inflammation, instability, asymmetry, and neuromuscular issues, correcting with low-risk interventions if possible, and then, if appropriate, escalating to Regenerative Med treatments that utilize the best possible products from your own body, specifically tailored, bespoke tailored to your own condition and needs, and delivering those cells using the highest level of image guidance. Make sure we're being very precise with what we're doing. If interested in getting evaluated, contact us via our website, chicagoarthritis.com. Again, you can email us, call us, contact us via any of our social media sites, and we are here to help. Wonderful. Let me just quickly look through one last time to see if there's any other questions. Great. Okay, wonderful. Well, listen, thank you everyone for your time. If you signed up for the webinar, you'll get a link for a replay. If not, you can check out our website or check out YouTube or any of our social media sites, and you can see it there as well. Feel free to share it with any friends, family, or colleagues who you think might benefit as well. Until we connect again, I hope everyone stays healthy and lives well. Bye-bye.